Hello everyone, and I am Dr. Anupama Chowdhry Devgan, your Physiology faculty. And this is the daily quiz series for NEETPG 2025, and we are on day 7 of Cardiovascular System and Respiratory System questions. From tomorrow onwards, I start General Physiology and Muscle Physiology. I will be discussing 5 questions every day for the next 1 week. So let's have a look at today's question. The first one. A 37-year-old woman is found comatose in her kitchen in rural India. Blood gas analysis reveals a normal PO2, but less than a normal arterial saturation. Which of the following conditions is most consistent with the findings? Now, we know that when you look at the oxygen content of the blood, this is the total oxygen which is present in the blood is in ml per 100 ml. This is the oxygen in combination with hemoglobin plus the dissolved oxygen. Right? And how do we calculate the oxygen in combination with hemoglobin? We take the hemoglobin in grams per deciliter into 1.34 into the percentage saturation. Now, why did I multiply by 1.34? Because 1 gram of hemoglobin can carry 1.34 ml of oxygen. Now, let us see what happens in hemolytic anemia. In hemolytic anemia, there is a decrease in the hemoglobin, but whatever hemoglobin is present, it is low, definitely. But that hemoglobin has a normal saturation. So that means the hemoglobin is reduced. Saturation is normal. This results in a decrease in the oxygen carrying capacity of the blood. And remember, in hemolytic anemia, dissolved oxygen or the PO2 will be normal. But the question says it's a normal PO2 with a reduced saturation. So this is not hemolytic anemia. Let's look at carbon monoxide poisoning. Now, in carbon monoxide poisoning, the affinity of carbon monoxide and heme is 210 times the affinity of oxygen and heme. So what happens is, now we know that each hemoglobin has got 4 heme, and let's say 1 has got carbon monoxide. Once carbon monoxide binds with the heme, it is an almost irreversible combination. It cannot be displaced. So now the heme available to bind with oxygen in the arterial blood has reduced. So the saturation of the arterial blood reduces. Dissolved O2 will be normal. So that means this is exactly what the question is asking. Normal PO2 with a less than normal arterial saturation. So let's see what happens if it's a hypoventilation, option 3. In hypoventilation, because less ventilation, so the PO2 will be reduced and therefore saturation will also be reduced. Let's see if it's a low VQ ratio. Same thing. How do you get a low VQ ratio? When ventilation is less than the perfusion. So that means, again, there will be a low PO2 and a low saturation. So the only condition where the PO2 is normal but the saturation is reduced out of these 4 options will be carbon monoxide poisoning. Let's have a look at the next question. The blood pressure in a 65-year-old male is 190 by 100. His pulse pressure systolic minus the diastolic, right? And that is 190 minus 100, which is 90 millimeters of mercury. He has no other symptoms. A decrease in which of the following parameters would be the cause of such a high pulse pressure? Let's try and understand this. Now, pulse pressure has got 2 determinants. Pulse pressure is directly proportional to the stroke volume. More the stroke volume, more the pulse pressure. And pulse pressure is inverse to the arterial compliance. More the compliance, less the pulse pressure. Less the compliance, more the pulse pressure. 2 determinants for pulse pressure: stroke volume and arterial compliance. So let's try and see. It says decrease in which of the following would cause a high pulse pressure. Myocardial contractility is low, pulse pressure will be low. So this is not the answer. Less myocardial contractility, less stroke volume, less pulse pressure. Less stroke volume, less pulse pressure. Less stroke volume, less cardiac output, less pulse pressure. But less arterial compliance, more will be the pulse pressure. See what happens in the elderly. In the elderly, there is sclerosis of the blood vessels. Blood vessels become stiff. So what will happen to the distensibility of these blood vessels? Reduces. So there is a decrease in arterial compliance, and that causes an increase in the pulse pressure. When you look at the blood pressure in the elderly, it may be 180 by 100, 190 by 100, wide pulse pressures because of a reduced arterial compliance. Let's look at the next one. It says, which of the following is associated with the third heart sound? Closing of the atrioventricular valves, the mitral and the tricuspid valve, this is responsible for the first heart sound. Closing of the semilunar valves, aortic and pulmonary, this is the second heart sound. And we know that the second heart sound is normally split. That is because the aortic valve closes before the pulmonary valve. Both the valves do not close at the same time. And what happens to the splitting of the second heart sound with inspiration? The splitting widens. Why does it widen? Because the closure of the pulmonary valve is delayed during inspiration. In rushing of blood into the ventricles due to atrial contraction, this is the fourth heart sound. Please understand, normally fourth heart sound is not heard. It is heard in conditions of decreased ventricular compliance. What do I mean by ventricular compliance? See, when the atria contract and blood goes into the ventricles must expand to accommodate this blood. If the ventricles do not expand, if there is a decrease in ventricular compliance, it will produce a sound. A decreased ventricular compliance, for instance, in cardiac failure, we can hear the fourth heart sound. Normally not heard, heard in cases of decreased ventricular compliance. In rushing of blood into the ventricles, in the early to mid part of diastole, this is responsible for the third heart sound. Third heart sound is a very soft sound. It is not very easily heard. It will be heard in young adult males with a thin chest wall. S3 becomes prominent in conditions of volume overload. So this is about the third heart sound, and my answer to this question is D. Let's look at the next one. It says, a 22-year-old male has significant blood loss in a motorcycle accident. His blood pressure on arrival in the emergency is 90 by 55 millimeters of mercury. All the following changes will occur in this patient except. Now, such a low blood pressure, a low mean arterial pressure, this causes a decreased stretch of the vessel wall, a decreased firing rate of baroreceptors. Remember, baroreceptors are your stretch receptors. Less stretch of the vessel wall means less firing rate of the baroreceptors. Less the firing rate of the baroreceptors, what is the effect on the sympathetic discharge? Increases. There is an increase in the sympathetic discharge. Parasympathetic discharge decreases. So what do we expect? If there is an increase in sympathetic and a decrease in parasympathetic, it will cause an increase in heart rate. Definitely. Increased sympathetic discharge, right? Increased sympathetic discharge will now cause, number 2, a peripheral vasoconstriction. And if there is a peripheral vasoconstriction, what will happen to the total peripheral resistance or what is known as the peripheral vascular resistance. This will definitely increase. If there's a vasoconstriction, less radius means more resistance. Resistance is inverse to the fourth power of radius. A very common clinical correlation, whenever there is a patient who presents with significant blood loss, if you touch his extremities, they are cold. Why are they cold? Because the peripheral blood vessels are constricted. There is less blood flow to the peripheries, right? So that more blood flow can be, blood flow can be maintained to the vital organs. So peripheral vasoconstriction. Increased sympathetic discharge, definitely. Now, what is going to happen to venous compliance? Again, what is compliance? Distensibility. The veins are thin-walled vessels and highly compliant, highly distensible. Normally, 2/3 of the blood volume is present on the venous side because veins can expand, they can accommodate blood. But whenever there is a sympathetic discharge, there is also going to be a venoconstriction. Yes, veins do not have sufficient smooth muscle to cause an increase in venous resistance, but they do cause a decrease in venous compliance. Please understand, arterioles and veins are different morphologically. If you look at the arterioles, they are thick-walled with plenty of smooth muscles. So whenever there is a sympathetic discharge, there is an arteriolar constriction. Arterioles are your seat of peripheral resistance. Arteriolar constriction means increase in the total peripheral resistance. What I just told you, cold extremities. What is going to happen on the venous side? Yes, there will be a venoconstriction, but not sufficient to increase the venous resistance. What happens here is there is a decrease in the venous compliance. The veins are not as distensible. And because they are not as distensible, more blood starts flowing towards the heart. This, in fact, increases the venous return. So the answer to this is C. We will not see an increase in venous compliance. We will see a decrease in venous compliance. Next, all of the following are true about the mean systemic filling pressure. Now, what is this mean systemic filling pressure? Mean systemic filling pressure and mean circulatory filling pressure. These two terms are sometimes used interchangeably. But mean systemic filling pressure is going to record the pressure in the systemic circulation, circulatory filling pressure, both systemic as well as pulmonary circulation. Mean systemic filling pressure excludes the pulmonary circulation. So let's try and understand what is this mean systemic filling pressure and what is the significance. It is the pressure recorded in blood vessels. When I say blood vessels, it means both arteries and veins. When the heart stops beating and the circulation stops. This is true. When the heart stops beating and the circulation is at a standstill, that means I've created a cardioplegia. I've stopped the heart from beating. There is no force from the heart, right? Or I could even clamp the great vessels entering the heart or emerging from the heart. If I clamp the great vessels, again the circulation will stop. So when the heart stops beating and circulation stops, the pressure in all vessels, that is arteries and veins, this will equilibrate. That means, what is equilibrate? That means it will come to one value. And that equilibrated pressure is known as the mean systemic filling pressure. Now, there are two determinants of the mean systemic filling pressure. Which are the two determinants? Number one is blood volume. More the blood volume, more will be the mean systemic filling pressure. And number two is the vascular tone. But more important than vascular tone is the venous tone. Right? So it is mainly affected by blood volume and the venous tone. Blood volume and the venous tone. This is true again. Normal value is 7 millimeters of mercury. This is also true. Increase in mean systemic filling pressure decreases venous return? No, in fact, it increases venous return. So what is a false statement is D. So let us try and understand what is the relationship between mean systemic filling pressure and venous return. Now, to understand this, please remember that flow through any tube depends on the pressure difference at the two ends of the tube. Flow is directly proportional to P1 minus P2. More this pressure difference, more the flow. And it is inverse to the resistance. So flow is delta P by R. Now for venous return, what is P1? P1 is mean systemic filling pressure and P2 is right atrial pressure. This is for the blood flow through the veins. Why is right atrial pressure P2? Because we know that the superior and the inferior vena cava will drain into the right atrium, right? This is the right atrium. So right atrial pressure becomes P2. Now mean systemic filling pressure is P1 for venous return. And what is mean systemic filling pressure? I just told you it is the pressure in the vessels when the heart stops beating. That means there is no force from the heart. And this depends on the blood volume and the venous tone. Now, why do we say that the P1 for venous return is mean systemic filling pressure and not the force from the heart? Because you must understand, when the heart pumps blood into the systemic circulation, blood goes into the aorta, arteries, arterioles. Now, arterioles are the seat of peripheral resistance. Very large resistance at the level of the arterioles. Arterioles are your resistance vessels. So as soon as blood crosses the arterioles, there is a very sharp drop in pressure. When blood goes into the capillaries, we don't talk about a systolic pressure or a diastolic pressure. We now say the pressure in the capillaries is hydrostatic pressure, pressure due to a column of blood, hydrostatic. So the point I'm trying to make is that because the resistance in the arterioles is so high, by the time blood comes into the capillaries, there is nothing known as a blood pressure. Now, when the blood goes into the veins, what is going to drive the blood towards the heart is the mean systemic filling pressure. So for venous return, the formula becomes P1 minus P2. So here P1 is mean systemic filling pressure, P2 is right atrial pressure divided by resistance to venous return. So normal venous return at rest is 5 liters per minute. Mean systemic filling pressure is 7 millimeters of mercury. Right atrial pressure is very less. We take it as 0. It is about 0 to 3 millimeters of mercury. So you can calculate the resistance to venous return. Now, a lot of times I'm asked this question that if mean systemic filling pressure is 7 millimeters of mercury, is this force sufficient to push the blood towards the heart? Remember, the blood now from the lower limb veins has to move against gravity towards the heart. So is this force sufficient? Definitely not. So that is why veins need valves, deep fascia, muscle contraction, deep inspiration, to help in venous return. It needs other factors for blood to flow in from the veins towards the heart. This force itself is not sufficient. Venous return is aided by the presence of competent venous valves, deep fascia, muscle contraction. The deep inspiration helps in venous return. Posture, the effect of gravity. If you go into lying down position, the effect of gravity is lost and there'll be more venous return. Blood volume is also an extremely important factor affecting venous return. How does it affect venous return? Because it affects the mean systemic filling pressure. More the blood volume, more the mean systemic filling pressure, more will be the venous return. Less the blood volume, less the mean systemic filling pressure, less the venous return. So another question I'm asked is that if I increase the sympathetic discharge, there will be increase in the mean systemic filling pressure. Definitely. There will also be some increase in the resistance to venous return. But because the increase in mean systemic filling pressure is more than the increase in resistance to venous return, what will happen to venous return? Increases. So these are some important points about mean systemic filling pressure and how it affects venous return.